Here's our clinical vignette for this week's case. Feel free to pause the video and take a closer look at these symptoms. Moving on to the ECG. It's very tempting to make a spot diagnosis because it seems so obvious, but we have to stick to our steps. So first thing is rate. Let's find an R wave that's at the beginning of a big box, right here, and count how many big boxes until the next R wave. So between 3 and 4, and since it's closer to the edge of the fourth, we'll call this just over 75 beats per minute. We'll call it 80 beats per minute. This rhythm looks regular, but normally we would do our paper method on a rhythm strip. Since we don't have a rhythm strip, we won't do that right here. We have to look for P waves next. So let's zoom in to lead 1, and we can clearly see before every QRS is a distinct P wave and no extra P waves like we might see in A flutter. For QRS complexes, let's zoom into AVL. We want to start at the Q wave and go to the edge of the R wave, and we see that that's 2 boxes, so that is less than 3 boxes or 120 milliseconds, so that's normal. PR interval. Here's the beginning of the P wave, the beginning of the R wave. That is 1, 2, 3.5, so that is less than 5 small boxes or 200 milliseconds, so that too is normal. Now let's look at ST segment. The obvious changes here are in the precordial leads. So if we were to look at lead V3, we would notice the ST segment right there is significantly higher than the isoelectric line. And that is true of almost all precordial leads. And so we can say safely that there is ST segment elevation in this tracing. As a summary, the rate is 80. We're in normal sinus rhythm. P waves, QRS, and PR intervals are normal. The significant finding here is ST elevation in 1, AVL, and V1 through V6. The interpretation here, an ST segment elevation myocardial infarction. So what's the pathophysiology of this case? STEMIs occur when there is cardiac tissue death due to ischemia. Ischemia is just lack of oxygen to the tissue, but when this gets carried too far and the tissue dies, that's called an infarction. When you see an ST segment elevation myocardial infarction, that represents transmural ischemia. Typically, these patients will present with central crushing chest pain that may radiate to the jaw or arm, but diabetic patients, elderly patients, and sometimes female patients might get atypical presentations like dyspnea, diaphoresis, and nausea. Some interpretation tips for STEMIs is to look for the key features. So obviously ST segment elevation is the characteristic finding, but you may also see in these leads a deepening of the Q wave. A significant Q wave is one that is more than 1/3 the height of the corresponding R wave. In addition, certain STEMIs will present with reciprocal ST segment depression in opposite leads. In this particular case, that can be seen in 3 and AVF. Looking at some examples, this is a hyperacute anteroseptal STEMI. So we're looking at an anterior myocardial infarction. So we'd like to look at primarily leads V1, V2, and V3. So if you notice, lateral leads like 5 and 6 do not show much elevation above the isoelectric line, but V3, V2, and even a little bit in V1 are higher than their corresponding isoelectric lines. So this is what we call an anteroseptal STEMI. Here's an anterolateral STEMI, so a lot like our original case, looking at lateral leads 1, AVL, 4, 5, and 6. We can see that significant ST segment elevation. So what are some takeaways for STEMIs? These can often be easy to spot on an ECG, but it must be important to recognize them clinically and to be acted upon quickly. The clinical presentation is often more important since it can be variable. And caution, if you see ST elevation in all leads, you're more likely dealing with pericarditis than you are an ST segment myocardial infarction. Thanks very much, and we'll see you on our next video.